Okay, so we'll move on in the spine here, and now we'll talk about myelopathy. So we'll start out with a little bit of congenital disease, MS, inflammation, trauma, syrinx. We probably won't get to neoplasm this year. Okay, so let's start with congenital. We'll talk about some variants, cyst, blocked vertebra, diastematomyelia. We've already seen a little bit of that, and some vascular things. Okay, let's see. Who did the last one? Sam? What?
I did the last one.
You did the last one? Okay, there you go.
Okay, so sagittal and axial T2, fluid signal intensity along the right neural foramina. So any cyst, kind of cyst,
Okay.
total cyst, yeah, perineural cyst, right?
Yeah. Yeah, there's several different names for these.
Yeah.
Good. Okay.
Looks like it's an abnormal dens. Looks like it's probably congenital.
Okay, so you can see that there's a defect here.
Yeah.
On the base of the dens. These are thought to be congenital. They're not that uncommon. If it's due to congenital reason, most people say that they're not at marked increased risk for instability. If it's due to a fracture, then they are at increased risk for instability at this level. But that's a variant. And, okay. Shiv, what do you think of this case?
32-year-old man CT exam after MVA. So it looks like the anterior arch of C1 has not fused.
Yep. This is a known variation. Posterior arch defects are much more common. Okay.
Okay, we have another abnormal looking dense process here. It's probably congenital or bone trauma.
So this one I'd be a little bit more concerned about for a couple of reasons. One is we really see a lot of space here. I also see a lot of eburnation at the end of the bones. And eburnation typically means that there's motion there and injury to the bone, which produces the hyperostotic changes. So this is one. And also it turns out in this particular case that this fragment here was fused to the anterior process of C1, which probably means that this is all traumatic and is probably not congenital in this case. So this is someone who I'd be concerned would be at increased risk for instability at the base.
Okay, so 60-year-old female with pain, worsening flexion. Okay, so is it atlas is a little bit
We have a little thing here.
right.
This thing there. I want to go to an extension.
It's moving.
Here's the vertebral body. Here's the anterior process of
C1,
which
is moving.
We're seeing a lot of motion here.
Right.
So what do you think?
Didn't fuse.
So this is in hyperextension. The patient is more symptomatic in flexion, however. And what you see in extension, there's a lot of space here between the posterior aspect of C2 and the posterior
arch
C1. When you go to flexion, notice how narrow that space becomes. So when they flex, they actually compress the cord or the medulla at this particular level. So this is a very unstable defect in the dens here.
Can we see, please, doctors, the X-ray?
It's a congenital fragmentation or something?
My guess is that this one's post-traumatic, but I don't know.
Okay.
So, what is that? I'm trying to understand.
So there's that fragment. There's the anterior arch.
Yeah.
Here's the dens.
Yeah.
That's in extension. In flexion, there's the dens, which is now moved posteriorly, narrowing the canal here.
It looks like there's a little separation of the fragment superiorly.
Yeah, well, it's a little bit of separation and flexion, a lot of separation and extension.
I was trying to understand where the abnormal motion is. Is it because it can't be the dens, right?
It's between the dens and C2.
But what I mean is that I saw on the X-ray. What I don't get is why it's causing that narrowing. Like, what's actually moving? Is
What narrowing are you talking about?
Of the canal.
Okay, so what's happening, if we did a CT inflection, then the dens would be back here, and you'd have a narrow space here, because the dens would be posterior to the anterior arch.
I'm thinking it's C1 really that's abnormally moving, isn't it? With respect to the dens, I would imagine because two
they're moving with respect to each other.
Yeah,
they're moving with respect to each other. There's not one versus the other, but clearly there's motion of C2 versus C1 here, and then here are just some axial images. We see some cystic changes here, and that's significant instability.
That's great. Okay, a lot of bone fusion here. Chronic neck pain. Okay. I don't see any like edema. I don't think so. But a lot of fusion.
What's causing the fusions?
Either old surgery or I wouldn't think trauma. It looks more like surgical.
We don't see any postoperative changes.
Okay. How old's the patient? Is it Klippel Feil maybe? I don't know.
So certainly think about Klippel Feil. These were congenital fusions. In this particular case, this patient did not have Klippel Feil. These were congenital fusions. I think we'll see Klippel Feil in a minute. Right. So that produces abnormal stiffness and then increased strains at the levels that aren't fused. Okay. Shiv.
42-year-old woman with shoulder neuropraxis after skiing accident. So again, we see multiple fused cervical and upper thoracic vertebral bodies. Again, I'd be thinking congenital, possibly Klippel Feil.
Right, and you can see that there's scoliosis, there's a defect, and the vertebral body here in this case, and this was Klippel Feil syndrome, and it increases risk of traumatic injury. Okay.
Progressive quadriparesis. We have exaggerated cervical lordosis. And 2, 3 at C1, C2. Yeah, there is like posterior subluxation of the C2 with regard to C1.
C2, right?
Yeah.
And there's C1.
It's out of C1 kind of. Okay, it's not in the arch.
And here we're kind of looking down the ring of C1.
Yeah. It's dislocation, C1, C2. Okay, there's cord compression.
You think so? Sorry. So this is also all congenital.
Congenital, yeah.
And this is a congenital cord compression.
Was the patient symptomatic in that last case?
Progressive quadriparesis.
Progressive quadriparesis.
Okay, that makes sense.
Does it make sense? I don't think flat out.
Well, if it's slow and it's congenital, it's amazing how a lot of function can be preserved.
Right.
Okay, so two sagittal images T1, T2, and seems like there is increased signal within the junction or proximal cord, cervical cord.
Okay, so there's abnormal signal here.
And lots of thickening of the ligament transfer.
Okay, and there's a lot of soft tissue thickening here.
There.
So you want to look for erosions of the dens. I don't see any clearly here. But clearly there's compression here of the cord.
Right.
Some axial images.
Yeah, we see that thickening again.
So what are you thinking about in terms of cause here?
Sometimes, usually the Perineural formation can do that, or pseudo.
Okay. So you certainly need to think about rheumatoid arthritis.
Right.
This is a place where rheumatoid arthritis
Right.
likes. You can certainly have this kind of synovial thickening. It's usually associated with erosive disease, but it doesn't have to be. But there's something up here in this particular patient as well. And then your axials. And then here, plain films. So this is kind of
another extra fragment.
This is flexion, and this is neutral.
On flexion, it looks like it's widening a space there.
Yeah, so there's a lot of widening here. So we have instability again.
Right.
And there's actually a lossicle up here. So this is a patient who had an Odontoideum.
Extra piece.
And they can either be congenital or acquired. And that's associated with instability at this level, which this patient clearly had. The acquired tend to be more associated with instability than the congenital.
This one needs fusion.
Right. Yep. Okay.
Some kind of.
This one's not so easy here. It'd be better if we had the other images. This is just another case of an Odontoideum with instability. But it'd be better if we had the sagittal images. So let's get that one. So how do we differentiate between the two? One is considered congenital, though a lot of these probably aren't congenital, and one is a fracture. To get more of a wide separation if it's congenital, more regular margins if it's fracture with a tilted odontoid. But yeah. Okay, why don't you take this case?
I guess there's a question of lytic mass. I wouldn't have thought a lytic mass here, but there's some fusion of 2 and 3, including the posterior elements.
So here's C1. Here's kind of C2. We're seeing something that looks very kind of odd here. So this probably is a fusion between 2 and 3 with the posterior elements, and then we can see what they were concerned about here.
Okay, maybe. Yeah, again, it's just bony fusion. I don't think there's a mass. Right?
This was just bony congenital block vertebra or bony fusion, and there was no mass there. Good. Chef?
Okay, I think I had this case before. It looks like an absent right pedicle with widening of the neural foramen.
So we have widening the foramen here. What's happening over here? Well, what do you see on the sagittal images?
Oh, let's see. Is there fusion here? I think maybe couple of the facets are fused.
So this is widened.
Yeah.
What's happening here?
Oh, yeah, the neural foramen is wide, and
Here's the pedicle below. We're not really there. I think we saw this in the lumbar spine yesterday, not in the cervical. This is a congenitally absent pedicle, and you end up having 2 neuroforamina together, and you get these kind of typical deformity of the remaining of the elements here, right? And you don't have a pedicle at that level. No, it shouldn't be symptomatic. As opposed to this is a chronic, I think this one we did see before, this is a chronic dislocation of the facet joint with the deformity next to it, which can also produce an enlarged neuroforamen due to the perched. And here we can see these are just above and below. That's the level, and then below look normal, and this is the level of the perched where we have the perching, we get widening of one side because of the abnormal rotation. Okay. Okay.
14-year-old with neck pain after football injury. Okay, we have disc protrusion at C4, C5, narrowing of the spinal canal. Yeah, it looks like there might be a fracture of the C2 right there. Yeah.
There's the CT.
Okay, it looks like well corticated.
Okay. Here's the axial, that's C3.
Okay, it looks like we have
C6.
C3 and C6.
Actually, see, so this is the normal.
Yeah.
So the normal, you basically have the facet joints here. What we're actually seeing here is a fracture at this level. It's really on both sides, bilateral congenital spondylolysis. If we go back here, here's the spondylolytic defect right here. And that allows a subluxation, so you get this kind of appearance. Now, there's a debate about whether these are truly congenital or whether these are all actual fractures. I think in the lumbar spine, they're almost all fractures. Fortunately, they're pretty rare in the cervical spine, but my gut feeling is that they're probably traumatic in the cervical spine either, rather than being congenital. But if they're seen in young people, they're called congenital. Okay. And then we can talk about Chiari malformations. Actually, why don't we stop here? I don't think we have time to get through all of this. We'll stop here and we'll talk about Chiari malformations tomorrow. Or not tomorrow, Thursday. Okay. Any questions so far?
Thank you.
Yeah.
Well, have a good evening, everybody.
Same with you, John. Thanks for joining us.
Thank you.